Well, thank you very much. And isn't it great to be back together again? It's a real pleasure, and thank you for the invitation, Albert, to come to be part of the conference today. Now, I'm going to be talking about will there be change to the NHS dental contract in England? And it's a sort of million-dollar question, isn't it? We could have been asking this question for almost, it seems like forever, doesn't it? Almost a professional generation. And I don't know if you're like me, but I sort of like mark and remember dates in relation to when I qualified. Now, I won't go back to that much ancient history, but this is me getting my PhD in London in 1993. And I can remember it particularly because I was 6 months pregnant with my eldest son, Matthew, at the time. And he's now operating as a surgeon in the Royal Liverpool Hospital. And so this marks the passage of time for me. Years and years and years are going on. Now, in the same year as that graduation, there was the Bloomfield report, Kenneth Bloomfield report. Now, you may be all too young to remember the Bloomfield report. Does anybody remember the Bloomfield report? Yes. Fundamental Review of Dental Remuneration came out in 1993, the year that I graduated with my PhD. We've been talking about these issues for a very long time. Now, this is quite interesting online to see this parliamentary mandate signed by 84 MPs to say, well, what's the government's response to the Bloomfield reports? We're against a backdrop in the country. We're concerned that there's a fall of 9% patient registrations at the dentists. There is, and a quote, you won't be able to read the slide here, but there's damaging speculation and instability in the profession. You could almost have written it today, couldn't you? But, I mean, I'm not ignorant at the fact of the amount of speculation that there is in all types of media and the sort of commentary that now we have about the dental contract in England is just wall to wall, but not just in the way that it was there in 1993. It's there particularly on social media now. We're living through a different era, and it feels like it has a harsher tone to it, and to some extent it sets the climate for things going forward. And we are in a different place, aren't we? I mean, it's undeniable that we've all lived through a pandemic, and there has been impacts on the profession of the pandemic. For example, the dental services were shut for a while, and that's created, as in the rest of healthcare, and particularly primary care, general practice, there are significant backlogs. It's had a further impact on quite low morale in the profession. And people are starting to, as some of you may have been, and some of our colleagues may have been, evaluating their work-life balance, etc. And then there are impacts on public sector funding because of the cost of the pandemic and it emerging out of the pandemic, etc. So this is the backdrop where we are with contract reform at the moment. And in the last 12 months, we've also had the summary and the results of prototyping. So I haven't got time in half an hour to go through all of the results of prototypes, but I'm just going to share with you a couple of the headlines because they influence the direction of things going forward and the next steps. So I'm going to spend most of my time, unfortunately, not announcing exactly what changes are going to come into place because they're not quite ready yet. But I'm going to give you some of I think it's a useful opportunity to tell you some of that longer term vision and how we will approach things going forward in terms of reforming the dental contract. Now, as many of you will know me as an academic, and I have worked in the CDS as well, and I've been a member of BASCOD since I graduated many moons ago. And I've really, up until 18 months ago, when I joined the Office of the Chief Dental Officer as Deputy Chief Dental Officer, I had a very front stage view about what happens in terms of engineering changes to the dental contract. But it's been really interesting for me to not just be writing about the experiences, about the impacts of the dental contract in terms of the frontline teams and in terms of the literature around incentives and governance, but taking a backstage view and experiencing how policy is made and having a fuller realisation that those that make decisions are not always the same people that set the policy, and how these, as Maggie said yesterday, in terms of trying to influence change, shouting louder and harder at people actually is not that effective, and it can be counter-effective too. So there are sorts of things like that that I've experienced over the last 18 months that sort of has given me a bit more of a rounded view of the whole complex situation in terms of dental contract. But before I get into the detail, I think it's because we're about building back better at the moment, I think it might be an opportunity to also think, to crystallise what are the biggest challenges that face us going forward in the future, because in any change to what we're doing with the dental contract, we need to have a very clear idea in terms of reform, where we're going and what we're trying to fix and what our priorities are emerging from the pandemic. So this is a quote here from Robert Francis, he was the chair of Healthwatch. That if we're talking about building back better, we, particularly in dentistry, it's an area of healthcare, isn't it? And I'm particularly passionate about this, that we see the greatest amount of health inequalities expressed in the population, in their experience and in their levels of disease. And so if we're going to build back better in terms of dental services and the contract, we need to have put a high priority on building back fairer, so that people should be prioritised who need the service the most and have the capacity to benefit most from the service and the resources. Because inevitably, particularly in England, we don't seem to be as fortunate as in Scotland, as we heard yesterday. We're building back better, and we have to be quite realistic about building back better within a funding envelope that is existing at the moment. If we calculate reform and changes on the basis of a bigger funding envelope, we can be wasting a lot of time and not be able to move forward. So we've got to plan the existing changes against the funding status as it is at the moment. But the balance of our priorities is going to be, and some of these issues are surfaces, and I'll tell you a bit about focus groups in a minute that we held in the reform process over the autumn last year. We've got to do something about health inequalities and building back better, so that people who have access to care should be reflective of their ability to benefit. But we can't do that without an adequate NHS workforce. And that's not just dentists. That means whole team working. That means retaining and recruiting people from GCP, but also dental nursing, because some of the access issues that there are in the country are made particularly worse, and this is some of the pandemic effect actually as well, where you can't recruit dental nurses because they've gone to work in Lidl's where they don't have to work PPE, and they have a better career development opportunity, and they're respected and valued in their workplace. Now there are aspects of the workforce that we need to take account of, but the attractiveness of the NHS relative to the private sector is something that we're going to have to think about. And undeniably, we have those morale issues. Now, focus groups would tell us with frontline clinicians and dental teams that morale issues are very real, but they're not always all to do with financial remuneration, because there are other strands that make people feel that they don't want to work still within the NHS sector. And there are issues about treadmill, but there are also issues about feeling that the contract remuneration and situation is unfair between for example, differences in UDA values, etc., and also feeling not valued and recognised and relatively isolated within when you're working in dental practices. And then moving forward, we also need to think about outcomes, and this is a real challenge in terms of incentivising prevention, because if we're going to work within the current funding envelope, we've got to think about how do we prioritise and support high clinical value care. And that's quite difficult. If you look at the amount of funding that we do have that is spent on checkups, that is actually quite significant compared to actually the needs in the population, where in Liverpool, I know because I've spoken to people interviewing them in the outpatients in the dental hospital are basically eating soup because they can't get adequate care. Now that's not acceptable, is it? But to move forward, we've got to place a high priority on high clinical value care. These issues are not simple. I mean, people would say, well, we would have fixed it by now if they were. But there's a fundamental tension here between what would be an ideal world in terms of a frontline dentist practicing, who will be very satisfied and motivated by being able to use a full range of clinical skills that they learnt at university with high-end materials, have lots of time with the patient, have lots of independent professional autonomy, delivering a high quality product. But if we're working within constraints, and we're also undeniably, who comes forward for dentistry in this country is very much driven by demand rather than need, and you can see that with the amount of with the type of people that come for very regular checkups. We have to think about how we can balance that against spreading that resource so that we can provide for as many people in the population as possible. And that's the opposite pole almost from quality, and that's efficiency. How do you get the maximum efficiency, the maximum activity per unit cost? And so there's a fundamental tension here, and it's not new, actually. This is another quote from 1993. It's a tension that is there throughout of all of health services. And this is what reform tends to be about across health services in general. It's trying to get to an equilibrium between the calls upon the budget, between efficiency, equity, and effectiveness. So all of those things are sort of need to be married together, and it's not going to be ideal offer from the point of view of just one stakeholder. You have to be able to work to get the best product for your given budget. Otherwise, if money was endless, we could probably satisfy everybody, but it might not be the best value for the population and the taxpayer. So this is why it's quite difficult, and this is why we're in a situation where we continually have a pendulum going, and it's quite hard to get a settlement. Now, the essence of reform, and I think this is a really useful quote here, is a sustained, purposeful change in order, and that means incremental change in order to move forward to get to that equilibrium. Because if you line up the different remuneration models and looks at the pros and cons of every single remuneration model, there are pros and cons to each one of them. And what you will find is unintended consequences, perverse incentives from almost any type of model that you put in place. And so what is a preferred and usually adopted reform as process, as you would have, say, in the Chinese rural health reforms, would be more of this type of thing. So that you're moving forward according to a strategic position and direction. So you're making sequential improvements to the system. So the dental care system is a complex system. It's not just about a dental contract, which once we've finally sorted what the profession has been wanting for 30 years, everything is going to be fine. It's a complex system. It's to do with workforce, it's to do with a whole range of things, as I've just illustrated. There is no right or wrong dental contract. There will only ever be a better or worse version. But we want to get to a better version. And we know that no change is not an option. It's been stated, and I think that's a really helpful place that we're in at the moment. Because we had a letter that was sent to the profession at the end of March last year. And this is, I think, this is where my backstage appreciation is probably more fully developed than it would have been previously, because the significance of this letter is actually quite important, because and who it's signed by. It's signed by a very, very senior person right at the top of the NHS tree. And the NHS has the responsibility to decide what they do with the NHS budget. So they're the commissioners. They're going to be deciding what is going to be adopted. It's not just following advice. They're committed to this. Then it's also signed by the then Minister for Dentistry, Joe Churchill. So there's government support behind this reform, and it's also signed by the clinical advice that's given to NHS England in the Office of the Chief Dental Officer. So there's a commitment to go forward, and at that time, we're just coming out of the prototype phase. The prototypes were run by the Department of Health with the analysis by the BSA. And at that time, the responsibility for reform has passed to the NHS. Now, that's the difference between making policy and being the decision maker, because whatever happens, it needs to be decided in the NHS. And also in that letter, there was a commitment that where it was possible to identify short-term gains to improve the current situation, we would look to do that, and there was a commitment to do that, and particularly over the last 6 months, that's what we're committed to do, exactly that. But before I go in to tell you a little bit about what has happened since that letter, I want to just tell you a little bit about that backdrop about prototypes. Now, prototypes, as you know, have been going on quite a long time, but the key findings that were coming out of the prototypes, and here, if you look at the black line here, those are comparator GDS practices who were matched by demographics for those within the prototype system. These are wave 3 practices who were going to be more similar than the pilot practices to the a national rollout of a programme. And then you'll see the coloured line, those green lines, those were the practices that underwent the prototype remuneration model that was a blended model of capitation and payment for UDAs. And you can see while the number of unique patients went up over the 3 years of prototypes slightly, the numbers of unique patients within prototypes fell by about 10%. Now, I think that might have been acceptable to NHS England in terms of value for money. If you could have argued that they were seeing fewer people, but that effort was focused on high needs patients over the 3 years. But actually, if you then break it down in terms of, say, health inequalities as indicated by the percentage of those unique patients who were exempt from dental charges, and then when you look at the solid red line here, you can see that they actually saw quite a lot fewer compared to the comparator practices. So they didn't really tick the box in terms of reducing health inequalities either, which is two of our quite high priorities, looking for a new system, particularly emerging out of the pandemic period. Now, I haven't got time to go through the other slides, but generally speaking, the other headlines are that activity was lower, as you can see from band 1, band 2, band 3. They're similar shapes, basically, in the prototypes. They go down quite significantly for all of that. But unfortunately, it's really hard to even argue that the prototype, as measured by the software that went into the prototype system showed that there was no improvement, no substantial improvement in terms of adherence to delivering better oral health or application of fluoride varnish. For example, the rates of application of fluoride varnish in children was actually lower in prototypes than in non-prototype, the comparative practices. In adults, it was slightly higher, but only by about 1%. So that's another issue that makes it quite hard to argue for a rollout of the prototype model. A positive of the prototype model was that the adherence to NICE guidance was better than in the GDS situation. And the other elements that were tested within that prototype model, for example, the DQOF metrics, they weren't applied in terms of a contractual sense with money attached to them. So it's quite hard to be able to also argue for that going forward. And then in terms of patients' responses, the patient's satisfaction is quite high anyway. And inevitably, if you give a patient satisfaction survey to dental patients, you can expect most of them to score in the 90% region anyway. But that's something about patient satisfaction surveys as a whole, because satisfaction is very much framed by what the patient expects anyway. So there was a slightly greater satisfaction with that prototype model, but we have to be quite guarded about interpreting that, because with the nature of the flow and returns in to dental practices, there's quite a high non-response rate. So it's quite hard to argue for a full adoption of that prototype model given a post-pandemic situation. But no change is not an option. And so with the transfer of the programme to NHS England, a process of reform has been in place for just over a year now, and it started in April last year with an advisory group was set up with the usual set of stakeholders that are outlined in the slides. And these issues about reform, those meetings were held monthly for a period of time. They were both high and low level issues, where we were talking about things like what should be covered within an NHS dental contract, etc., as well as the pros and cons of different remuneration models, etc. And this is similar to the process that was put in place to reform the GP contract. It mirrors what the approach to reform that they had, in terms of they also had an technical working group that informed that some of those discussions and recommendations and work that was coming out of that. It was very keen to reflect in that technical working group a mixture of academics who could provide things like health economic advice, public health advice, but also frontline clinicians that don't necessarily have a stakeholder view, because you get a different view from a wet-fingered dentist that doesn't come to a meeting to express their view in their capacity of somehow representing a sort of like a group, for example. So we had a number of really helpful and insightful people and continue to work with them going forward. It was so useful that we held a series of focus groups between August and November last year. And what we did to really recruit and involve people as far as we can in a representative sense, the invitations were sent out via the online system Compass, and then there was a random selection for participants, and then we balanced them by age, and gender and type of contract, etc. So the number times two, for example, for contractors, we had 2 focus groups there involving 19 people, and 225 people put themselves forward for that. So you can see we had about 10 focus groups, and we held separate focus groups for different types of members of the team, and that was really helpful, because once we talked about the bigger issues to do with the NHS, we were really surfacing. So a lot of the issues are about the contract, but they're also about the system and how we can improve the system in an incremental way. So reform is happening. It feels like it's taking a long time, But we have actually been in a negotiation stage between NHS England and the BDA for quite some time. And the reason why you haven't had a running commentary on this is that we want to give this the best chance of success, because if you start to discuss it in public, the actual sort of content of reforms, you start to advocate in public rather than a room when you're trying to sort these issues out together. So this is just a picture for people that don't know the people involved. The tall gentleman here is the Director of Dentistry and Optom for the NHS, and the smallest lady in the burgundy cardigan here, that's Rachel Foskett-Tharby, who's the Deputy Director, is working really closely. Now, she worked on the reforms in general practice, and her PhD was on the QOF metrics within general practice. So that's the type of people that are involved in this reform process. And the other people in the room are Sean Charlwood, who is the chair of GDPC for the BDA, and then you'll recognise Martin Woodrow. Shiv is the deputy for the GDPC, and then you've got the policy advisors from the BDA. So that's who's been involved in the negotiations. Now, in order to go into negotiations, you have to have cross-government agreement. This is the backstage bit, and it explains a little bit why the process takes so long. But so we started the discussions, and these are focused particularly initially on interim changes. We started to have the discussions last November, and the cross-government mandate to have official negotiations came in March. Now, in order, there is an outline agreement for initial changes that is now been with the BDA for a few weeks. So, and then we will need to have another cross-government agreement for those to go into legislation. And then we'll move forward from there. But that won't be the end of the process. Those will be the first set of incremental changes to the system. And I emphasise system here because we're not going for one ideal new shiny contract. I want to end with a quote. I don't know if you've seen the Barack Obama's speech, the speech that made Barack Obama president. It's a really good speech, actually. But I think it's pertinent to sort of say, what can I do, given that some of this are in public health. But there's a phrase when he talks about his vision for the longer term that I think is actually quite pertinent for us to think about going forward. Because when these reforms are announced, I think if we want to move forward as a profession, it would be really good to see not the politics of cynicism, but the politics of hope. Because when you have that narrative, going back to the narrative that I explained earlier, this has a framing effect on the opportunities for reform and likelihood of further funding, etc., down the line at a whole sort of different level. So in terms of stakeholders, I think that we should be talking up the reform process rather than talk it down. So thank you.